You had time with a good lunch. Then we are still few, but you can start. We are a good few. Then we have a very important part of the health system, the neonatal and child under 5 part of our life. This is welcome. Kole, welcome. We are starting. This session is to discuss the 5 years of our life in this world, very critical part of the life. Then, I think in terms of logistics, I think it is everyone knows that we are translation. We can have interpretation in English and French if you need it. Otherwise, then I was saying we discuss improving neonatal and the child health, the aspect of the management of this part of the health system, inequalities, and policy implementation. Then I'm with my colleague, Angela. Angela, she will capture findings and the recommendation. Key one. Applaud for Angela will help us for this important work. Then we have six persons. I will not call them presenters, but I call them people who provide insight on the topic. Then we can, all of us, contribute to this topic. We have Stephen Lee Mwaseba, we have Mary Hadley, we have Wanangwa Manda, we have Prince Agu, we have Jean-Claude Mvaneze, and we have Turate Innocent. I will not introduce them, they will do themselves. Then we can go quickly. Then I would like to invite my friend Stephen. Stephen, you have the floor.
Yeah, good afternoon. Yes, my name is Stephen Mwaseba. I am from Tanzania, but current PhD student at Stellenbosch University in South Africa. Yeah, I'm here to present my work on progress with the title Rural-Urban Socioeconomic Inequalities in Child Stunting in Tanzania, taking the role of antenatal care visits. So without wasting the time, could start with the I could start with the introduction. Basically, I wanted first to clear about the key concepts, that is child stunting, as well as to clear the key issue concerning antenatal care. So what do you say about child stunting? We say a child is stunted actually when he or she is shorter compared to her age group. And normally we measure child stunting by the use of height for age Z-score, which is the standard deviation, whereby WHO puts the standards that if the height for age Z-score is less than -2, means that a child is stunted. But the key question is, why do we concern about child stunting? What's the rationale of doing research regarding the child stunting? Is that child stunting has an implication, social and economical. We say that child stunting can distort the individual ability, meaning cognitive and physical ability, which later may impact the productivity, and then may impact even the cost related to the health expenditure due to the impediments of stunting. Moreover, we say that child stunting is more common in the rural areas compared to the urban areas. We can see, despite various interventions, but the gap is still there. Rural areas, prevalence is high compared to the urban areas. And then we also concerned with child stunting because it's basically distributed unequal across the socio-economic dimensions. We can see the distribution of child stunting based on the economic status. We shall see later on what the literature says about child stunting in relation to the economic issues, economic and social dimensions. And then why are we concerned with antenatal care linking with the child stunting? We know that antenatal care are those care that a mother receives during the pregnancy time. So why are we concerned then with the antenatal care? It's basically among the interventions to reduce child stunting, but they are underutilized, especially in the developing countries, as has shown by those scholars. Moreover, we say that despite the free policies of these maternal and child health care in Tanzania, but still individuals incur other costs. For instance, like transportation costs and the other related costs. And then we concern with these INC visits simply because we have seen in the past decades that the FANC, meaning the focused antenatal care, has been increased, but stunting prevalence is still very high. Yeah, we can see here the trend of antenatal care and child stunting from 2010 2022 in Tanzania. There is an increase in antenatal care utilization, while there is decrease in the child stunting prevalence. With all of those, still there is a big gap between the child stunting, between the rural and urban areas concerning the prevalence. So the key issue here is what the theory of change between antenatal care visits and child stunting. We say that basically here we are talking about the two aspects. During the antenatal care visits, the mother do receive some of the diagnostic tests, received some of the supplements, which are very important for the growth and development of a child. So we say that stunting of a child could start from the utero. So it's very important. It's very important to put it clear about the significance of the antenatal care during the pregnancy and after the pregnancy. So we can see here after the pregnancy is that during the visits, the mother do receive the maternal education, which is very important in raising the child. Which is very important in raising the child at the age of under 5. With all of those, there is limited evidence showing the association between antenatal care visits as well as child stunting. And simply, I could say that the contribution of this study is just to add the insights about the association between antenatal care visits and child stunting in Tanzania, as well as the methodological contribution of this study, given that other studies has applied the logistic regression and others has applied the concentration index and the decomposition analysis. With this study, we are going to use the reweighted recentered influence function decomposition analysis that is some more sophisticated compared to the other ones. So quickly on the conceptual framework, I was just trying to show how the flow of these antenatal care to the child development. If you look at the first row, you can see the role of the government. That's why we at the end we are supposed to provide the insights that could change the whole system from the government from the system structure up to the maternal health and the child development. Yeah, on the method part, I could not talk much about this, but all I can say, we have used the data from the demographic and health survey for Tanzania of the 2022. And the sample size in this study was 2,782, as well as those are some of the variables. I mean, those are the variables I used, but basically, I wanted you to note, like, I didn't include the birth weight variable in the analysis, despite of its significance in determining the child stunting, due to the missingness of the data. So, with the inclusion of this birth weight, it leads to the bias results. That's why we excluded the birth weight variable, though it did not affect much the robustness of the results. So on the part of the empirical analysis, I will not go much on those formulas, but we used we measure the inequality by the use of the by the use of the standard concentration index, which basically was expressed by Wagstaff in 1991. And this one, we say that the results from this concentration index actually shows if the inequality, is it pro-poor or pro-rich? So that's all. This inequality was not much important, but it was crucial to know the results of this inequality measurement. And then I used the decomposition analysis, which is the reweighted recentered influence function or worker decomposition. Basically, this one, we say it combines the two, it combines the reef regression and the Owaka-Brinder decomposition. That is its strengths. Why are we combining it? I mean, why this is combining this? We say that the reef regression normally determines the inequality within one group. But the good thing of the Owaka-Brinder decomposition analysis, it can determine the inequality between two groups. So combining them made the method to be robust. So the key issue that I will present in the results is that this reef or worker decomposition analysis, it separates the result. I mean the total difference. What I mean when I say the total difference is just the gap between the rural and urban inequality. So it separates it into explained and unexplained effect. So speaking about the explained effect, it means that we say that the effect is explained within the model. But unexplained effect, it means the effect in that model is explained by an observer that has not been shown in the model. And another issue which is very important here is that the leaf or worker decomposition, it decomposes the inequality gap or that difference into various contributing factors. So here is very important that the leaf or worker determines the gap, and then it shows how much that those variables included in the model contribute to that gap. So this is the very key issue in this part of the empirical analysis. Yeah, going to the results. We see from the results there, child stunting is worse in rural areas compared to the urban areas, as you see there. in the fourth column, as well as we can see that similarly, antenatal care visits is less compared to the urban area. So you can see like there is some sort of correlation between child stunting as well as the antenatal care visits. Somebody could ask, why am I using the 4 ANC visits while there is a WHO guideline which says a woman must attend at least 8 visits. Basically, I use this one because the guideline is there, but in principle, the reports are mostly shown by the use of these, four visits. Coming to the results of the standard concentration index that I said that to measure the inequality. In the methodology, I said that here the aim is to show if the inequality is it pro-poor or pro-rich. As I've said prior, that if the inequality is positive, we say that the inequality is pro-poor. I'm sorry, pro-rich, meaning that that inequality is in favor of the wealthier one or the richer one. But if the inequality is negative, we say that that is the pro-poor inequality, meaning that the inequality is in favor of the poor. So we can see here from the results, antenatal care visits is in favor of the richer individuals, while child stunting, that is hate for GZ score, is in favor for the individual. I'm sorry, for the poor individual. So we can see the relationship that antenatal care visits is something that is limited to the poor individuals. The same individuals are the one who are affected much with child stunting. So with this one, we can say that the results suggest that the intervention in the urban areas should be more aggressive, targeted to the poor, whereas in the rural areas, broader initiatives could be some more effective. Another key issue maybe here, you can see the inequality, you see the coefficient for the urban and the rural. You can see, for instance, antenatal care visits, the coefficient for the urban is somehow bigger compared to the rural, meaning that the inequality gap is bigger to the urban population. So this is very obvious because these people in the urban areas, remember that we are ranking these visits regarding to the wealth index. So I think even in the normal life, we see that there is high disparities in income between the poor and the richer in the urban areas compared to the rural areas, where they most like share the common economic situation. But this gap does not actually mean rural areas are somewhat privileged compared to the urban areas. So in the part of methodologies, as I've said, the key issues that I put out to be discussed here is the gap, as I have highlighted there, the total difference, and how those, how the covariates, or how factors contribute to this gap. So that is my main focus. So I not discuss other results, but you can see there, the total difference of the gap is 0.098. Okay. The gap is 0.098. So the aim of this decomposition analysis, see the next table, is just to see. Remember, our focus was on the antenatal care. So we want to see how does the antenatal care contribute to that gap. You can see it contributes to 0.032, which is almost like 40% of that gap, and it is statistically significant. So from this point, we say that the results has shown the clear association between the antenatal care visits and the inequalities in child stunting. Yeah, with the robustness check, I will not discuss, but we did it to see the strengths of the results. Yeah, we did some of the robustness check to see the strength of the results. Okay, so sorry. So in conclusion, we say that it's clear that there is a significant correlation, association between the antenatal care visits and rural-urban inequalities in child stunting. And basically, the recommendation that has been put in is like to improve the mobile clinics and telemedicine to reach the rural areas and the poor. And lastly, the areas for the further studies has been proposed as they are shown there to focus on the causal analysis study as well as employing the mixed method, that including even the qualitative studies. Thank you so much.
Good afternoon. Good afternoon. My name's Mary Hadley. I'm Director of Context in Development. Until recently, I was in Rwanda. I retired from full-time work last July, having worked 45 years in Africa and Bangladesh. It was about time to stop, pass the baton on to the children, who are continuing. But I'm not here to present my own study. This is a study on behalf of Dr. Pascal. And it's about the challenges faced by families when their babies are admitted to neonatal units and the implications of those. And there are actually people in this room who are also helping with the study. I see Elia Silas was involved. I don't know if Jean-Baptiste managed to get in. Yeah, hi. Yeah, also involved with this study. So this was a joint effort. Next slide. So reducing neonatal mortality is one of the current global health challenges, and it's also a challenge for Rwanda. CHUB, a hospital in the south of Rwanda, it's about 650 neonates a year, and a quarter of these are from district hospitals. The length of stay varies from 1 day to several months. Next slide. So the overall objective of the study was to improve the neonatal outcomes and patient satisfaction through gaining a much better understanding of the challenges that mothers face when their newborns are admitted to hospital. Next slide. So methods we used, in-depth interviews, 20 mothers were interviewed, and that was the point that data saturation was reached. There was no new information coming. And these were of mothers who'd had their newborns admitted to CHUB in February 2023. And we used open-ended questions, just 4 questions, one of them on finance, just to ensure there was no bias from the researchers. Analysis was done through thematic inductive approach, and there were 5 independent persons involved in the analysis, and that was to reduce bias. So the results will be presented in key themes: circumstances influencing the hospital stay, experience of the hospital stay and the consequences of the newborn, outcomes and the family situation. So this is the first. The circumstances influencing the hospital stay, they included the existing poverty within the households, the distance from home, and not every village can have a health facility with a neonatal unit. No country in the world has this. So this is how it is. This is how it has to be. But it does mean that people can't be brought in food from home, other items from home. They can't spend the night at home. They can't continue their informal income generating activities. And this is confounded in this situation by the long unexpected stay. So the next slide. Those were some quotes from the women who were interviewed. So staying at the hospital was not easy, especially before the neonates were admitted to kangaroo care. There was no designated accommodation for the mothers after delivery. Mothers slept outside, even shortly after cesarean section. If medicines were not available in the hospital, then the family had to go to the private pharmacy, look for these medicines and pay the full price. And caffeine, which was one of the medicines that was prescribed, is 9,000 per vial. And that's 900 if the mutuals are paid for, but 9,000 if they had to go to a private facility, just to put it in context. The mothers were given 2 meals if they could get to the canteen, otherwise they missed out. The toilets were very few and far away. There were long queues for the toilets. And all these difficulties were compounded because of the worry and the anxiety that the mothers and families had of their very sick, tiny babies that were admitted to the hospital. Next slide. I leave you to read the quotes while I'm chatting, because I'm sure you're not listening to me. So you can be reading the quotes. We found some potential direct consequences on the newborn outcomes and the family situations from these testimonies from the mothers. The families lost opportunities. Sometimes they lost their jobs. They had to sell livestock, sell land and other assets. Mothers had to be near the newborns all the time to give breast milk every few hours. And to produce that breast milk, they needed diet and fluids. And don't forget, the toilets are very hard to get to, so they're not going to be trying to drink a lot of fluids. They had to make choices on whether to eat or to buy medicines. Not all of them, but some of them. And they just couldn't always do both, in which case the neonatal suffered. Or else the stay was prolonged because the neonate was not gaining weight. The next slide. Yeah. So the conclusions of the study, and this is no surprise to any Rwandan. Everyone knows that when the babies are admitted to the neonates are admitted far away for intensive care, that it's very difficult. They're challenged by the unplanned event, the distance from family, with long-lasting financial implications. Imagine if land and assets are sold, employment's lost. And then on a day-to-day basis, they struggle to find accommodation, they struggle to find food for themselves while needing to provide breast milk and find funds to purchase medicines. Next slide. So the recommendations are to provide shelter, daily meals, and access to the toilets for the mothers of the hospitalized newborns, to provide free medication for newborns if the families are unable to afford them, and to ensure that the stocks are sufficient within the hospital so stockouts are not experienced, thus passing on the cost to the burdened families. So this is Dr. Pascal. He's very sorry he couldn't be here. He's in India. He's here in this photo with a baby born severely premature, but survived and now continues to be monitored periodically. And I'd like to say that since this study was first presented to the hospital management have implemented many of those recommendations, accommodation, the toilets, and stockouts of essential medicines. So that concludes the study. I think I was quick. Thank you for listening, and I hope that was useful.
The next person or something. Good afternoon, everyone. Yeah, good afternoon, everyone. So while we're waiting for them to put up my presentation, I recall when I stepped in here, I know. So when I stepped in here, the moderator said something that so do I have to point the pointer that way? Okay. All right, let's not be so distracted. So the moderator said something that this section would focus more on the first 5 years of our lives, which is a very critical moment. Yes, I definitely agree with what the moderator said. However, it is also important that we understand that we have children who are above 5 years, 5 years and above. And in many instances across many low, middle-income countries, especially in the global south, you discover that there is so much attention being given to children 0 to 4 years, and almost no attention given to them from 5 till about 17, in most countries. In Japan, I think about 3.5 trillion yen have been budgeted to ensure that childcare policies are made and childcare policies are implemented for kids between 0 to 4 and kids between 5 to 17. So my argument today is going to be that as much as we want to focus on children between 0 and 4 years, we must also give the same amount of attention to kids between 5 and 17. So with that, I think I'll start the presentation. Yeah. Okay, finally. Now, in the case of Nigeria, you can see that factually and frankly, the Nigerian system recognizes the fact that kids between 5 and 17 years, of course, in Nigeria, 18 years is the age for the commencement of adulthood. And so we have policies that tries to consider and take into consideration the health of kids between 5 and 17 years. And some of those policies, you can see them there, the Child Rights Act, the National School Health Policy, the National Policy on the Health and Development of Adolescents and Young People. And then we have the Child Health Policy, that captures the health and welfare concerns of children from 0, to 17 years. But the problem is these policies don't seem to translate into welfare and well-being, of children, in the society, in the real life case. And that's why we have all of these quite sad statistics. About 12 million children in Nigeria are stunted. The first presenter spoke to that. And you can see that that's 32% prevalence, and it is the second highest globally. You can see also that 97.5% of children in public schools in Nigeria lack access, to public primary healthcare services. And also you can see from two measures, the Kids' Rights Index and the Child Flourishing Index, you can see what the position of Nigeria is. This is Nigeria. Lots of African countries, also rank poorly, in all of these measures. That's the CFI and the Kid Rights Index. If you look at the Kid Rights Index, it covers issues of education, it covers issues of health, it covers issues of social protection, it covers issues of nutrition, and so it brings together some sort of holistic picture of what the concerns of kids between 0 and 17 years are like. And so in a sense, I will be trying to shift your attention from always wanting to think about kids as those that are 0 to 4 years. Because if you look at most policy documents, it's about under 5. And so now we'll be looking at the possibility of how do we extend same amount of energy, to kids that fall between 5 and 17 years. It could be 5 and 15 years in some contexts, depending on what the age of adulthood in those contexts are. Are we doing something about this? Yes. In Nigeria, we're currently running a project and we're working with stakeholders from various ministries and agencies that are concerned about kids, from the Ministry of Women Affairs and Social Development to the Ministry of Health, to the Primary Healthcare Development Agency, to the Child Rights Implementation Committee. So we're working with all of these agencies and ministries and parastatals, and even community stakeholders, religious clerics. We're working with them. And in our first meeting, we published these communique, which states that child healthcare isn't for infants and under 5 alone. That's the message I want us to take home with. That whenever we talk about child healthcare, whenever we talk about child health policies, we shouldn't always think about those that are under 5s. We have those between 5 and 17 years, as the case may be in diverse contexts. And so this is the further context to say that the case of Nigeria isn't a case of nothing has been done. So if you look at all of the policies, there are lots of emphasis, on the fact that we need to pursue like the National School Health Policy, which looks at fostering healthcare and safety for children in schools. If you look at the National Child Health Policy, it emphasizes how there must be maximal linkage between primary healthcare facilities, and schools. If you look at the Child Rights Act as well, it is very emphatic on the fact that we need to protect, our children. And when it mentions children, it isn't just talking about 0 to 4 years. It is talking about kids that fall even between the years of 5 and 17. But the problem is that, like I said, we're engaging stakeholders, we're engaging agencies and all that. And so we asked the Ministry of Education that you have all of these wonderful policies, but then nothing is being done. And then the Ministry of Education said that we realize that it is important that we take care of these kids in our schools, that we ensure that they have access to health services. Like the study I just quoted that stated that 97.5% of children in public schools in Nigeria lack access to public primary health care services. The Ministry of Education is saying we understand all of these, we realize all of these. You took so much of our time. But that's by the way anyway. And we asked them, so why is nothing being done about this? So the Ministry of Education said, the schools do not even have so much money to facilitate teaching and learning costs, let alone asking these schools to not focus their resources on health costs. And so what do? We had to track back to the National Child Health Policy that states that schools should in some way be linked to primary healthcare centers or primary healthcare facilities. The idea is that these primary health facilities should be able to provide some sort of health services, to these schools, whether you want to call it in the interim, but that is what it is that is what we have in the law, in as much as the Ministry of Education is faulting that. Now, we have to look through all of the policies, within the space, beginning with the Child Rights Act, to begin to say, Now that the space is this way and these kids are not protected as per their health, let's go back to the policies and see what we can do. We scanned through 4 important policies, beginning with the Child Rights Act, and we had to start looking at what their weaknesses are and what their strengths are and what the opportunities are, and of course, what the threats are. But you can see that it's not all bad. So there are some strengths, as you can see for the Child Rights Act. But the major problem there is the Child Rights Act dates to 2003. It's not been reviewed since then. It's about 22 years now. So there is need for us to just go back and look at those things again and try to make sure that they match the realities of the time. If you look at the National School Health Policy, this is the one that is very pathetic. Since 2006, it's a policy, it's not the law. The Child Rights Act is a law, so we can argue that you can't just review laws anyhow. But policies must be reviewed, maybe perhaps in the space of 3 years, 4 years, 5 years, as the case may be. If you look at the National School Health Policy, since 2006, that's about 19 years, nothing has been done about it. And as I would show further, you would see that because of the fact that the National School Health Policy is dead, is redundant, isn't doing what it should be doing, all other child health policies that should provide some sort of health protection for kids in schools are practically failing. The National Child Health Policy is failing because the National School Health Policy is weak. The national policy on health and adolescents, on health and whatever for adolescents and young people is also failing because the school health policy is weak. Even the Child Rights Act is failing because the school health policy is weak. And that's why I'll spare you all of these. These are stakeholders yeah. Oh, this is very slow. Okay. Yeah, there should have been some crash course on how to handle this before. Okay. Yeah, so these are folks we gathered, just to show the evidence. Yeah, and all of this. So I'll end this way. So if you look at all of these things, essentially what we're trying to say is that I will just quickly go to the end. Sorry. Yes. So I just come here. Essentially what we are just trying to say is we can't look at the way that the situation is from a narrow lens. We need some sort of whole of systems lens to look at this issue. We need to make sure that there is collaboration between the Ministry of Education and the Ministry of Health. Currently, there are some sort of rivalry between both ministries in terms of who should coordinate the National School Health Policy. We also need to make sure, if you look at all of those policies and even the Child Rights Act, didn't make provision for the voices of children, for the agencies of children. So we need to also make sure that we capture the voices and the concerns, of kids in the law and the policies that we have. We also need to make sure that the public understands that there are policies of this nature in place, that the Child Rights Act is even in place, because we've documented lots of violations of the health rights of children. We've documented lots of ill health practices, targeting children between 5 and 17 years. And the reason nobody's saying anything about it is because of the fact that nobody's paying attention, to the guys. And with that, I would say this. Thank you so much for listening to me. And my message to you as you're going home today is school health or child health or anything that has to do with health that concerns kids isn't for those that are 0 to 5 years. Those that are between 5 and 17 years, 5 and 15 years, 5 and 21 years, in whatever context, should also be considered. Thank you so much.
Good afternoon, everyone. I'm Jean-Claude Mumbaneza. I'm a biomedical engineer by professional. I'm from Rwanda. So I'm gonna little change from, if I may say, to the technical things. So I'm going to talk about preventive maintenance conducted in Rwanda. In fact, I would like to recall or to call your attention, when we say preventive maintenance, what does it mean? Preventive maintenance, let's take an example of your car. When you go to the station and change filter, that's a preventive maintenance. While curative maintenance is one, while the battery of your car is broken. So take this scenario to infant incubator or infant warmer in neonatology. If you change air filter of infant incubator, you're doing preventive maintenance. So if the maintenance is correctly done or well done, we save the life of our child. I might give you another example. Most of you here, you have already taken airplane, but you are quite sure that if an airplane is not well maintained, you're gonna not survive. Take that scenario to neonatology or maternity. So this study was conducted in Africa, not in Europe or in America, in small country called Rwanda. That small country has 30 districts. We conducted in 7 districts only. So we collected data before, during the intervention, and after intervention. Why did we choose those 7 districts or 16 hospitals? In that time, to 2020, in this area, in 7 districts, 16 medical equipment used in neonatology and maternity were not functional. You might say, Claude's not big number. But again, if it's saving life equipment, especially in neonatology, this is huge. 16 medical equipment used to save life of mother or neonatal child. The objective of this action research, we thought if we focus on preventive maintenance, we're gonna reduce curative maintenance. So we wanted to see the impact of this introduction of preventive maintenance. So we didn't invent anything. There's already documentation all over wide. So there is principle which guided us from WHO. What we did was to take in our local context. That means what? The same way an equipment in Paris is maintained is the same way it should be maintained in Gihundwe Hospital. Not saying because we are in Africa, the way we are going to do the maintenance should be different from the Europe or USA. So that means sustainability, quality, and affordable. So we sit down, we try to see how the system works in Rwanda. From the Ministry of Health, we had the Ministry of Health, we had RBC, Rwanda Biomedical Center, but we had 2 divisions from RBC, MCCH, Maternal Child and Community Health, and MTD, Medical Technology Division. It's a division who deal with engineering. And in middle, we have our hospital and maintenance workshop. But we could not take this subsystem as a big. So we took only in red from those division up to the health center and medical user equipment. When we say medical user equipment, we mean nurse, midwife, and doctors. So we try to understand what the gap existing in the subsystem we've chosen. We have in the middle, hospital maintenance workshop. Some people, they might say, no, there is no maintenance workshop. Here we mean staff. We are not meaning the building. They're already existing biomedical technician, our hospitals. So the first gap we saw, existing biomedical technician work as firefighter, only repairing. There is no preventive maintenance of those medical equipment. And we find, even if they work like firefighter to repair those infant incubator, CPAP, or ventilators, they don't have appropriate toolbox. Some of them, they try to perform preventive maintenance, but there is no record of anything done or conducted as preventive maintenance. Another issue was from the central level, medical technology division, there was no any supportive supervision to see what's happening in hospital or health center. And again, another challenge was like one-way communication on each entity. There was no any two-way communication. That if a biomedical technician needs a spare part, there was no any way to request a spare part from the management of hospital. And the same applies not only to the hospital, but to the district itself. That means the DG of hospital, if it doesn't have budget, could not request a budget to the district authorities. So what we did, we tried to put in action what we were thinking. We know our doctors, our biomedical technician, the director of hospital, they are well trained, but we try to do a kind of capacity building to put them together and to remind what they have to do. And we purchase appropriate toolbox for biomedical technicians. Instead of using a tool to repair an ambulance and same tool to repair an infant warmer in neonatology, we purchase appropriate toolbox. We try something which is tangible. If you've done something but is not written, it's nothing we did. So we try to strengthen the reporting and monitoring our medical equipment. And another thing, we elaborated a framework contract for repair, for emergency repair. We might do something special, talk, but without a budget to reinforce or to back up the hospital in case they don't have money. Again, it's nothing. Imagine in neonatology, they say CPAP machine is broken, but there is no spare part or fit. So we use this framework contract as emergency repair. And we set what we might say a clear system for maintenance, which we thought it could be sustained with adequate tool, paper, and reporting every monthly and most of the time annually. And we try to implement and elaborate preventive maintenance, as I said. After all those, we thought we might again require refresher training, not only for biomedical technician, but also nurses and midwife. We elaborated a booklet which could be taken in the pocket every time if you enter in neonatology and something is like out of your mind, there is an alarm on an equipment, what to do or what to call. So that was kind of refresher, hard copy and soft copy. And we tried to train again biomedical technician, even if we know they have been trained from school, but a kind of annual refresher training. Another thing we did is to put together biomedical technician and director of finance. Most of the time, sorry if there is someone from management here, there is a confrontation between biomedical technician and budget officer. There is no budget. If you don't do what you have learned, go away or go home. So here we try to put them together to have a common understanding. So we did a kind of mentorship supervision at health facility, not staying in the office or in Kigali. We try to go down in the health center and the hospital. One of things we find, if you don't conduct preventive maintenance on time, you're gonna do repair. This is one example of one infant incubator in Gihundwe, which 2 fuses was broken. And those 2 fuses, the cost of them, not even 1,000 Rwandan francs, 1 USD. That means this equipment could be put down and purchase the new one while it's something which is not expensive. So the main outcome of this action research, as I said, we tried to see if the number of functional equipment increased or decreased while we're implementing this preventive maintenance. In starting, the baseline was 0. So the baseline was 0 in 2020, and then at the end of 2021, we reached 63. At the end of 2023, we were on 88% of preventive maintenance implemented in neonatology. And updating inventory, because we require them to update their inventory monthly, from 9 to 89. You might say why there is a stack there. It was during the COVID time where nurses were very busy. And for the functional equipment, recently we were on 96. You might say again, why those 4% were not reached. Those are equipment, they are not human. You might say we have 100% right now, after 5 minutes, 5% is gone. So, implementing this preventive maintenance, we could manage to reduce curative maintenance. In starting, we used those lot of money for repair, while we reduced 91% of the budget. And I want to emphasize here, you might say this is not a big number, but this budget could be, if it was well maintained before, it could be used to purchase another new equipment. And this has inspired hospital management to start thinking, planning in their budget plan or annual plan, the budget for maintenance. The good things here, not only for maternity, but this budget plan was for the entire hospital. Even if the money was little, but at least they start understanding that maintenance is important. So as I said, if you establish preventive maintenance or you have a sustainable maintenance system, our hospital gonna run 100%, 7 days, 24 hours without disruption. And that means our baby, our mother will be in safe hand, as I said before, if you are in airplane. Behavior changes are very remarkable. Doctors are not sitting in the room and start purchasing only or doing the list of new equipment, but they are now understanding the importance of preventive maintenance and curative. However, you might say, what is the message here? We could say we saved this number of baby or mother, but at least with this figure of amount, we know that we saved someone indirect. That means preventive maintenance can save life and money. We face some challenges. Limited number of biomedical technicians in our hospitals. And we used only manual database. So the recommendation goes to the Ministry of Health and RBC. We are glad now the medical maintenance system management is running, but we want to be used at the health center as well. And we try to advocate to the MTD to do the mentorship and supervision to the hospitals and advocates to increase the number of biomedical technicians. I want to request you here. You, as I said, in airplane, when you know that the airplane is well maintained, we should take medical equipment the same way we took the airplane at the airport. I thank RBC and the all 7 districts. I thank you, everyone.
Okay, quickly, Turate. Quickly, you do quickly. We have time to also to ask you a question. Eh? Right. Yeah.
Yes. So my name is Dr. Turate Innocent. I'm a public health expert in Rwanda. So my presentation is about strengthening the coordination of referral system within the district for emergency obstetrical neonatal care. So it's all about mothers and the newborn. So the background is a well-functioning referral system is one of the key cornerstone of safe motherhood. Everyone knows about it because it's a statement from WHO. And globally, 2/3 of maternal deaths could be averted if appropriate access to emergency obstetrical neonatal care is available is in place, and if also time management is well managed, as I say, and the effort to improve referral system just target 15% of pregnant women who are expected to have obstetrical complication during childbirth. So we realized that in our setting in 7 districts where we were working, the number of referrals, women with obstetrical complication referred to higher level has increased by 41%. And the number of deliveries at health centers has decreased by 14%. And the number of deliveries at hospital has increased by 21%, meaning that the burden of referral process is becoming more and more important. So we need really to focus on the way how referral system is being done to ensure appropriate management of referred mothers and the newborn. The reason why we conducted a rapid assessment a rapid assessment of referral system to identify maternal and neonatal care referral system gaps. It was just to look for gaps. The objective of this assessment was to identify local system-based gaps associated with poor quality during referral and propose a recommendation that could maybe help the Ministry of Health to improve the way we are doing business. The specific objectives was to assess whether women and the newborn is appropriately assessed during the childbirth and identify if referral system is required. The second objective was to identify the level of preparedness at the health center level to check if they are ready to receive and appropriately manage emergency obstetrical neonatal care cases before referral, and establish quality of emergency cases management during the referral process, and also assess availability of information exchange and communication between health center and the hospital, and then determine the management of the referred patients once they arrive to higher level. So this assessment was we used a mixed method in order to look at those specific objectives, both qualitative and quantitative. It targeted 16 hospitals located in 7 districts, 41 health centers, and 37 ambulances. So we use different tools, for quantitative data, we use different tools, including HMIS, patient files, registers, and so on. Also, for the qualitative, we used interview and focus group discussion, but also an observation of existing tools, medicines, and equipment. So here, I will not spend much more time on this slide because, but I can say that there were inclusion and exclusion criteria. Inclusion criteria or all files of women and the newborn referred during the period from June 22 to July 21, and medical files that are of referral newborn and within the same period, but we excluded those who are referred without referral note, or those who are reported at hospital level without without referral note, and those who are not referred to higher level. Those with complication who are not referred to higher level. So the characteristics of the assessed data sites, as I said, most of them are health centers, but and most of them are in rural area. And in total, we have 342 women who were referred at upper level, and 21 newborn. And those who are referred, both women and men in the same time, we were in total, it was around 400 cases during that period. So those are results. The key, we are presenting the key results here. So we were, at the beginning, we were wondering if this referral system was involving professional staff, including nurses and midwives. This was the case. We found that most of those cases were referred by professionals. And also, those professionals were able to at least to assess, to make a clinical exams as appropriate clinical exam, like a chief complaint, physical examination, past obstetric history, patient triage, and patient stabilization before referring them. We assessed also the quality of management of emergency obstetric neonatal care based on key signal functions that are supposed to be in place at the health center level to ensure appropriate management and appropriate referral once the decision is taken. So we found that most of the case here, nurses and midwives were able to perform most of the key signal functions except the two. The two, which is perform assisted vaginal delivery with vacuum extraction. Here we call it ventouses, using ventouses, but also manual vacuum aspiration in case of when there was abortion. So during the discussion we had, during the focus discussion, one of the message kept our mindset was that the one which was done by a head nurse of a health center, she said that assisted vaginal delivery remained theoretical rather than practical for us. We lack both equipment and experience to perform those procedures. Even skilled practitioners avoid them without theater backup, preferring to refer patient rather than risk complication leading to maternal or perinatal death. So another key findings was incomplete information when we were checking different tools that are being used at the health center level to manage a referral system. The example here, the tools were there, but some information, key information were missing, like time of arrival to, time of arrival to hospital, and standardization of referral form, ambulance logbook, and so on. So those are the really key gap of incomplete information. So regarding the handover, we wanted to check if the handover was really correct, was done correctly between health center and the hospital. We found that most of the criteria used were relatively good, except medication reconciliation and patient triage. So we calculated the time between the response time between the call for ambulance and also the admission to hospital. It was 2.36 minutes. We also looked at the standard tools in place within the ambulances. We found that most of the ambulances were missing key equipment like defibrillator, oxytocin, which is a life-saving medicines that should be available in the ambulance, but also pre-transfer treatment was almost, information about pre-transfer treatment was missing. So regarding the coordination, there were some issues that were identified, including the coordination of, including, for example, the integration of ambulances within the emergency department. The ambulance services is not a standalone department within the hospital. It is integrated into the emergency department. Another issue was related to referral system-based hospital catchment area. We found that there were limited consideration of patient preference for reference. And we found also the assisted delivery at health center level, as I said, MVA was really missing, and it was missing without any backup surgical facilities. The last one was the limitation of strengthening referral systems. So it was really related to infrastructure, other infrastructure that are supporting the referral system, like adequate roads, geographical terrains, and climate change. Very quickly, with those findings, the Ministry of Health tried to put in place some solutions. Like in HSSP 5, we discussed about making an emergency medical services a standalone department in the hospital. It was also issue of upgrading some remote health centers into medicalized health centers. Medicalized health centers are managed by medical doctors and having theater in place for comprehensive emergency obstetrical neonatal care. We also discussed about the second choice of the hospital. And in last year, the Ministry of Health issued a ministerial instruction about second choice of a hospital that should take into consideration the preference of the patient. There is an ongoing on-time digital solution for tracking emergency cases that are being referred from health center to hospital. This is still in the process. Let me skip this intervention. Those are the intervention we did. But I want to highlight this on this one about reviewing the existing guidelines to ensure that the maternal referrals are being taken into consideration. As a conclusion, I would say that the referral system alone is not enough. It's a piece of puzzle. Strengthening referral system is a piece of puzzle in different interventions that are being put in place to improve maternal and neonatal survival. It cannot be enough. We need also to accelerate and improve the increased numbers of medicalized health centers. Thank you very much.
Thank you. Thank you so much. I think we had good insight in the topic. I would like to ask you to come here. Quickly, we have, of course, we start with some late time, 10 minutes. Maybe we see how to save it. Go, come, Mary, take place. Come, I will not spend much time to summarize. Let me give you the floor.
Yes.
Then we see how to get some takeaway after. We have another chair here. Okay. We have few time. If we need to save time for our break, let us go quickly. Just go straight forward to the question. 1 minute maximum. Let us take the list. Who would like to intervene?
Thank you to the presenters. I have a small question for the one who presented about the inequalities you showed that in your presentation, you said that antenatal care consultation was linked to the stunting table. So the consultation was coverage was low on the side of the stunting. So I'd like to ask you if you are able to look at the antenatal care services. Is package, the first two services provided from to what's the it is clear. Yes. Then the question is just continuing quality, Stephen, quality implication contribution to this inequality.
All right. Thanks so much. I could not be able to present the issues regarding the quality, but some literatures has shown the quality of the antenatal care is measured by the content that the mother is receiving during the antenatal care visits. And basically, the results also show that in terms of those contents, still urban areas are more privileged compared to the rural areas. So the quality was elaborated through the content of the antenatal care visits. I don't know if I've answered clearly the question.
Yeah, I think it's clear because also the difference of point of staff, the trained staff, all other things have implication on the rural and the urban, right? This is what we are saying. Okay.
Yeah, thank you for the presentation from Rwanda about the mothers, you know, when they have children and they have to be on admission, what they suffer from. So it's sources of poverty. So it's maybe we should don't know what you think, because it appears it's for problem with poor women, not general population. Number one. And number two, the recommendations do not have the house. You know, they are still like policy recommendations. I'm looking forward to, I mean, we have two key recommendations which should be done, but how will it be done? Because we will find that increasing the governments are no more interested in such recommendations. They want to know how do we want to, if you say provide money, how? Is it cash? Give them cash? So I wonder what I have further thoughts about. I know you presented on behalf of somebody, not your presentation, but on the house to achieve those recommendations. And then how, you know, to make it sure that it's for poor women, not general population. Thank you.
Yeah, thanks. That was an interesting question. Yeah. So it actually covered. There were very few women that didn't suffer in that particular hospital. They were coming from very far. With regards, but I think I did mention that not all women had a problem with being able to afford the medicines or the food. It was not all of them. There was accommodation available for, I think, 1,000 francs, but most of them could not afford that every day. And the how, actually, in Rwanda, many of the hospitals are different. So the hospitals here in Kigali, they have food given by some NGOs, some charities give food to all the patients. In that particular hospital, they didn't. The accommodation was made through, they put mattresses in an area near to some toilets. So that's how they solved the problem. So the women could sleep on mattresses. So what we've done in the longer term, the new hospital that's being built, maternal hospital in Kibagabaga, which is part of Kigali, it has in it a specific area of accommodation to accommodate those women. So it's not a policy, but the new hospitals are being built with that possibility for the women to be able to be provided accommodation and showers and facilities within the hospital itself. It also added, which was another study we did, was the birthing companions, allowing somebody to be with them the whole time. And the nutrition, yeah. So the nutrition was, there were those two, I don't know if they solved that problem, but again, in the big hospitals in Kigali with the NICUs, they don't have that problem. So it's an individual hospital issue. Each individual hospital has to see what they have, bearing in mind these are the challenges. And I think the thing was with this study that everybody knew this was going on, and it wasn't until we did a study using a proper sample and presented it as such that the administration, the management, took note and said, oh yeah, okay, this is terrible what's going on. We've turned a blind eye, and they could no longer turn a blind eye on it. And I think that was the key of this piece of research.
Yeah, thank you very much. I think I want to ask the question to us, both by yes. You are planning MDGs first, SDGs, you are saying the risk is under 5. Now, this is saying, okay, it seems the above 5 up to 17. It is a question we need to bring in our child health program. Then, what do you think about it? Can you come for it? With the gap designed in under 5. We would like to just to cover this new topic in our new system.
Just be one thing.
Yeah.
So to help you think about it, Nigeria has 100 million children. Of this 100 million children, just about 20% fall under 5. So you have about 80% of 5 to 17 years, not catered to by any health policy. That should be something for us to think about. Thank you.
Thank you. Our conference here is African Health Economics and Policy. Now, do we need to bring the CEOs children in our new planning? Do you think we need to become education? So, not this conference now, start to operate. Now, then we have some guidelines, some orientation. We have someone who would like to comment. Thank you. I think we need to do this because you can see the challenge in adolescents using drug abuse, alcohol, and all those substance abuse. I think children 5 years and the next
this is happening. I think we need to bring this group in this program. Okay, we conclude with some recommendation. Last one.
So thank you, everyone. So with regards to that, that there was so much emphasis on under five children and all of that. When we bring in 5 and above, so 12, it looks funny. Seems that some people say, "Man, how can you say a 17-year-old person is a child?" Which I feel will. So I think there should be certain age bracket that should get out, and then the health programs protect for that age bracket, maybe 6 to this to this. So of them is using 5 under 5 years down. Then you figure out point. So what I'm trying to say is 5, including 17-year-olds into under 5 health program. I think it's nice. Like, we're going to have problems with how can you say that 17-year-old person is under 5 or should be similar problems under 5? So I think there should be a different health program for 17 downwards. So that all of them into under 5 program.
Newborn to 17.
So from the newborn to 5, and then from maybe from the newborn to 10, and then maybe from 10 to 17.
But we can maintain the memory we can introduce, like go to the, we can introduce, to large and the 5, 17 from 5.
Yes.
Okay, I think I agree. And also, it can also be contextual because for his case, looking at Nigeria, looking at the number of under 5, they don't have much of a problem. But if a country has, in terms of the demographics, most of these children lie between 5 to 17, then there's a need for us to take a look at them. Usually now, the students entering, students entering first year, do have a number of challenges. So they come and then many small things, their mental breakdown. They have some mental issues and we are not able to take certain things into consideration. So I think this is also the time where we can look at them. As she mentioned, drug abuse, there are certain things that they are doing, maybe they're not even aware of. Some of them are aware of it, but if you're able to speak to it and make noise about it, parents and other people will get to know that this is an issue. And so a need for us to look at that. Thank you.
Thank you. Good. I think we have a very important takeaways. Let us bring to our policymakers some policies. As you say, so we are using a lot of not preventing not just to come firefighters that are there to have to program this is saving. I think this should be taken as very important element. Then few countries will have a very separate, I would say, some just very professional system to have emergency staff, to have technology, to have communication, to have mapping. I think this also should be, because this is also include save life, but it include also efficiency, how we are doing things, because we are buying ambulances, not well. We are very perceived to be a kind of having, as developed countries, a very organized ambulance emergency referral system. I don't know if this one you are doing with me, but I understand. For me, we should put as a takeaway first for about school age category. Second, our equipment, medical equipment, how can we take care in terms of preventive, how then to have a professional referral system with people who have capacity, we have logistics system and communication system. These are the three I would like to suggest you. If you agree, then we applaud, then we conclude our session. Take a picture. Yeah, this is okay. Then these I suggest, then as our colleague is suggesting, let us come together as colleagues, as brothers, as sisters, having a family picture. Welcome.
Can I just send you what I've done?
Yeah.
Check.
Can you join me? Yeah.
Good evening. I presume you guys are coming back from the tea break, so I expect a bit more energy. So thanks for joining this very interesting session. We're going to go ahead and get started because the time is not on our side. We're already about 15 minutes late. So this session, as you might have seen on your agenda, it's entitled Addressing Health Inequalities and Financial Barriers in African Healthcare Systems. It's a very interesting topic and it has very interesting presentations. The speakers for today is going to be a series of 5 presentations that we're going to go through. And I'm going to quickly go through the speakers so that I introduce them. If they can either stand or wave to the congregation, that would be good so that we know who's in the room and they know if they want to ask more questions later. So the first presenter will be Dennis Okova. Dennis hails from, he's Kenyan, but he's doing his PhD at University of Cape Town in health economics. He has interest in cancer research and he's confident that his research will contribute towards giving daughters, sisters, mothers, and fighting trends against reproductive cancers. He's really interested in reproductive cancer. So looking forward to hear from his presentation. The next presenter will be after Dennis. We'll have James Odiambo Ogota. Yes, James. James is also Kenyan. Yes. James is a health economist with expertise in decision and analytic modeling of health interventions. He's in his final year of his PhD in public health economics and decision science at the University of Sheffield in the United Kingdom, and he's focusing his research on cardiovascular disease prevention in Kenya. That's a little bit about James. Our next presenter is Okechukwu Timothy Uzor. I haven't seen him or her around. Okay, so we'll see when he comes, but if he comes, he's a clinical psychologist and a researcher within the health policy research group at the University of Nigeria. He also holds a PhD and master's from the University of Nigeria in clinical psychology. We have Evelyn Kabia. Hi, Evelyn. She's also a health economist and a PhD fellow at the Health Economics Research Unit at KEMRI Wellcome Trust Research Program in Kenya. She has keen interest in health financing, health policy, health equity, and gender in health. Lastly, we have Maria. Maria is a PhD holder, is a health system researcher and health financing specialist with almost 20 years of experience working in health system strengthening and financing, as well as public financial management. He has held many positions. She's currently a reader at Queen Margaret University, Edinburgh, and she's involved in a number of research projects, including Rebuild for Resilience and a UNHCR-funded project, which I believe she will be presenting on today. And she has worked as an ODI fellow with the Ministry of Health in Burundi and many other roles in the space of health financing and health systems. She holds a master's and PhD from London School of Health and Tropical Medicine. Thank you so much for joining us. Just before we go to the first presenter, I will give you some ground rules for this session. I will be asking that those who have mobile phones, if you can please put them on silence or switch them off if you don't have any other urgent matters. Make sure this is to avoid any disruptions. Then, since we have lots of presentations, I will encourage everyone to write their questions down, and then we can hear from the presenters. Later, after all have presented, we'll take a round of question and answers. And lastly, presenters will have 10 minutes to present their research, and I'll give you a 2-minute reminder for you to wrap up. So I'll be sitting there, and if I hold up a sign for 2 minutes, it will be your cue to kind of wrap up and then get ready for the conclusion. So thank you so much. I hope this is going to be an interesting session for you all. Let me now give the floor to Dennis for the first presentation. Let's give him a round as he comes up.
Good evening, guys. I hope you're not too tired for me. So I'll jump straight to it. So I'm presenting a study protocol of an ongoing PhD study titled Catastrophic Health Expenditure and Distress Financing of Cervical Cancer Treatment at a tertiary hospital in Cape Town, South Africa. Where do I point? Thank you. So for those who are not aware, what is cervical cancer? So it's cancer of the cervix, and it's caused by a virus, HPV virus, type 16 and 18. It It is one of the most preventable and curable forms of cancer if diagnosed early. Unfortunately, in our case, in LMICs, including South Africa, it's diagnosed at very advanced stages, which limits treatment options and leads to poor prognosis. So briefly on epidemiology, as you can see on your left, in terms of incidence, cervical cancer is the second most incident cancer among females of all ages in South Africa. And in terms of mortality, the pie chart on your right, it's the leading cause of cancer deaths among females of all ages in South Africa. So that is a very worrying statistic. In terms of projections of mortality and incidence rates, projections show that by the time we reach 2040, the mortality and incidence will have risen by at least 1.5 times. This is worrying for a disease which is highly preventable and highly curable. Since you're talking about out-of-pocket expenditures and catastrophic health expenditure, it makes sense for us to discuss briefly the South African health system. So in South Africa, they utilize a subsidized user fee system. And in this system, fees at point of use are fully subsidized for unemployed people and pensioners. While those who are employed and pensioners, they pay a subsidized fee according to their level of household income. So it's expected that the levels of out-of-pocket expenditure would be very low for this, for South Africans. And in conjunction, we expect that the levels of catastrophic health expenditure would be equally low. So briefly, some studies have quantified catastrophic health expenditure in South Africa. And among surgical patients, it stands at 2%. Among patients on reproductive assisted techniques, stands at 22%. Then among diabetic patients, 25%. And among HIV patients with TB, 55%. So to the best of our knowledge, no study has done this for cervical cancer. And that is the gap this study aims to fill. So we need this empirical evidence on catastrophic health expenditure in cervical cancer so as to support early diagnosis initiatives and also to strengthen financial protection initiatives in the country. And all this feeds into the global cervical cancer elimination initiative, the 90-70-90 target. For those who are not aware, this, the 90 aims to fully vaccinate 90% of girls by age 15, and then 70, it aims to screen 70% of girls, of women by age 35, and again by age 45. And then the last 90 aims to treat 90% of all identified cancers. All this by 2030. 2030 is 4 years away, so impossible. So I have 3 specific objectives. The first one, I want to quantify out-of-pocket expenditures incurred by women as they seek treatment for cervical cancer and understand how these out-of-pocket costs, they're distributed across the stage of disease and across socioeconomic status. Then I want to quantify catastrophic health expenditure and understand how it's distributed across stage of disease and socioeconomic status. Then the last objective, I want to examine cost coping strategies adopted as a result of out-of-pocket expenditures. So I'm doing a cross-sectional survey at one of the leading tertiary hospitals in South Africa called Groote Hospital. So this is a public sector tertiary facility, and we are interviewing women across all the stages of cervical cancer, across stage 1 to stage 4. Women currently on treatment. So the woman must be on some form of treatment at the time of interview. In terms of analysis, data and analysis, we are collecting data on out-of-pocket costs, and we are concerned about direct medical costs and direct non-medical costs. And here we want to understand how much these women spend out of pocket and what are the biggest drivers of out-of-pocket expenditure. Then we also want to understand if these out-of-pocket costs, they turn catastrophic for some patients. So what percentage in catastrophic health expenditure, and how is this distributed across socioeconomic status and stage of disease? Then we want to understand the various predictors of catastrophic health expenditure. The key ones will be the clinical features of the patient, stage of disease, comorbidities, treatment options, and other patient characteristics. And then finally, we want to be able to quantify distress financing. So what proportions of women are utilizing various coping mechanisms, and how are these coping mechanisms distributed by socioeconomic status and stage of disease? So what? So once you have the full data set, we would want to know, like I've said, the biggest driver of out-of-pocket expenditure. Would want to know catastrophic health expenditure. Then would want to understand distress financing. And with that, we can be able to identify the most vulnerable populations among these women, and perhaps target those for policy interventions. And in terms of policy implications, we anticipate that this data can be able to support early diagnosis initiatives, for example, by demonstrating the burden of catastrophic health expenditure across the stage of disease. We can make a case for investment in early diagnosis initiatives. And also want to strengthen financial protection initiatives. So what is the biggest driver of out-of-pocket expenditure, and what interventions can we tailor to mitigate those drivers? So I thought it wise to report some key challenges that we are facing during data collection. The first one, remember, we are dealing with a very vulnerable population. These are women who are in a lot of distress, and as such, getting data from them is not the easiest of things, but we do the best we can, and we adhere to the highest level of ethical standards. And also, because we want to recruit women at all stages of cervical cancer, this is a challenge because most women in the clinic, they present with stage 2B, stage 3, and stage 4. So which means that we will miss out on getting women of early stage cancer. And then the last challenge is we are collecting data from a very busy clinic. So this clinic handles close to 300 women with cervical cancer every year. And we haven't added other cancers, other reproductive cancers. So a lot is going on in this clinic, but yeah, we are finding our way through it. Thank you so much for your time.
Thank you so much. He actually presented under the 10 minutes, so calling all the other presenters to follow suit. So the next presentation is going to be from James. Yeah.
That just add the pressure. Thank you. So as the presentation is loading, my name is James Oguta. As has been said, I'm a PhD student at the University of Sheffield in the UK. My PhD focuses on modeling the health, economic, and equity impact of cardiovascular disease prevention in Kenya using an existing hypertension, diabetes, screening and management intervention as a case study. This piece of work forms one of the outputs from the earlier phases of my project, and it focuses on examining the socioeconomic inequalities in ideal cardiovascular health in Kenya using an existing secondary data set. So I'll briefly talk about what ideal cardiovascular health means. In 2010, the American Heart Association introduced the concept of ideal cardiovascular health, which is defined or constructed from 4 behavioral risk factors for cardiovascular disease and 3 biological or biomarkers: blood pressure, fasting blood glucose, total cholesterol, diet, tobacco, physical activity, and BMI. Of course, this was revised in 2022 to add sleep quality as a proxy for assessing cardiovascular health status in the general population. So in Kenya, 13.5% of the population use tobacco, about a quarter are hypertensive, and only 6% consume adequate servings of fruits and vegetables, and 18% have a high salt intake based on previous studies, with more than 80% having at least 4 cardiovascular disease risk factors. There are studies that have attempted to examine inequalities in various risk factors. To be specific, one focusing on hypertension, the other on tobacco smoking, but none has examined ideal cardiovascular health, inequalities in ideal cardiovascular health of the general population, looking at the total sum of all the risk factors. So we sought to do that with this study to assess the socioeconomic inequalities in ideal cardiovascular health, and then to examine which factors would be the major contributors or drivers to the observed inequalities. We use the WHO STEP survey for Kenya. Is the only data set collected in 2015. The next round should be preparation. Hope to update this at some point. Collected among adults aged 18 to 69 years and 4,500 individuals. So what did we do? We defined ideal cardiovascular health based on the 7 metrics and dichotomized the 7-point scale. There are various ways in which previous studies have attempted to define what is ideal and what is not. So any individual with at least 5 out of the 7 risk factors at ideal levels were defined in this study as having an ideal cardiovascular status. Of course, I know that's contentious, and that's why the 2022 metric sort of tried to create a 100-point scale to sort of define individuals in a more accurate manner. So we use principal component analysis to derive, construct the wealth index, using household assets, and included other predictors in the model, age, gender, and so on and so forth, as in the slide. So we use the concentration index to assess or rather plot the pattern of the inequalities, and then concentration curves, whereby if the curve lies above the line of equity, the 45-degree line, as we'll see in the next slides, we define that as the inequality being more, or the outcome being more concentrated among the poor, and vice versa. If it is below, then it would be among the rich. And then use the concentration index, which is a summary measure. Again, if it is negative, then a negative concentration index should coincide with a concentration curve that is above the line of equity. And then we performed Works type decomposition. Normalized, of course, I kept the equations out of this, but this paper is on preprint with all the methodological details included. So we found that about half of the Kenyan population have an ideal cardiovascular health, at least 5 CVD CVH metrics at ideal levels, almost male slightly higher, but not significantly different. This graph shows that among the higher quintiles, a higher proportion of those in the richest quintiles have ideal cardiovascular health, physical activity, BMI, and fasting blood glucose and cholesterol levels. And the pattern is different for fruit and vegetable intake and smoking. So from this graph, we see that the concentration curve is below the line of equity with a positive concentration index, which means that ideal cardiovascular health is more concentrated among the rich in Kenya. And of course, that is statistically significant as well. We did a sex stratified analysis, and from the 2 graphs among males, the curve sort of crosses and the bounds of the concentration index cross contain 0, so there is a significant inequality among females, but not males. Moving on to the next part, this table sort of shows the different matrices and the pattern of the inequality across the different matrices. So we see that from the overall inequality, total cholesterol, blood pressure, and BMI are among the rich. And of course, the pattern would be different, vary across the different sex groups. In this case, performing decomposition analysis, we find that urban residents, please load it again. So urban residents, wealth, and region of residence are the main contributors to the observed inequality. While there is a little, followed by education. Followed by education, ethnicity, and some little contribution by age and employment. Our variables explained about 75% of the inequality. These findings imply that there is need for targeted interventions at the poor, especially in urban areas, interventions addressing high BMI, especially among poorer households, and adopting gender lens in the design of interventions. Of course, physical activity interventions being key. Thank you very much. And to access the full text, thank you.
Thank you so much, James, for that very interesting presentation. I think many of you, including myself, I'm learning ideal cardiovascular health for the first time. So it's an interesting presentation. Thank you. A round of applause to him. The next presenter, okay, Chuku. He wasn't, okay, good. Thank you. A round of applause as he comes up.
Thank you, everyone. So my name is Okechukwu Ozo, and I'm the lead author of the paper. Unfortunately, my co-authors are not here. My Professor Bin Nawujekwe, who was initially here, I don't know, he left for something. So I'm going to present the I'm going to present all the groups available here. So what we did was that we assessed for the inequity in out-of-pocket expenditure among. So we assessed for the inequity in out-of-pocket expenditure among urban slum dwellers in 2 states in Southeast Nigeria. So basically, the issue of out-of-pocket expenditure has been described as a big, an unfair financing mechanism across the globe, especially for low to middle-income countries like Nigeria. So this out-of-pocket expenditure we've been mentioning centers involves making payments that without reimbursement, so no partial reimbursement or full reimbursement after you've made payments. For example, for health services, if assessed. So for the rich individuals, for the rich households, this may not really be a problem for them because after making such payments, they may still have some funds to do other things and not have to forgo some basic needs. But for the poorer households, they may have some issues. So that's where the catastrophic health expenditure comes in. Because I may walk into the facility to make some payments to access healthcare, and at the end of the day, I may have to forgo having to eat or buy other things, pay electricity bills and stuff like that, which becomes catastrophic for me. So one of the key thing about the health system is that they have to ensure promotion of fair financial contributions. So, and for them to be able to do this, for the health system to do this, they need to understand the intricacies of health inequities, especially across vulnerable populations like the urban slum dwellers. So, based on that, coupled with the fact that there is a paucity of empirical evidence regarding out-of-pocket expenditure across urban slum dwellers. So this was part of what necessitated us to engage in this study because there's positive evidence, empirical evidence on this. So our overall goal was to assess for the inequity, presence of inequity among the households in like I mentioned earlier, in 2 cities, Enugu and Anambra State, Nigeria. So one of the, more specifically, the first objective was to characterize the demographic and socio-economic characteristics of the study populations. So the second is to characterize the health-seeking behavior of these households. So the third is to estimate the association between out-of-pocket expenditure, health-seeking behavior, and socioeconomic status of these households. Then finally, the fourth objective is to explore the inequity, the presence of this inequity in out-of-pocket expenditure among the households. So the study was, it was a cross-sectional design survey study, which was carried out in Nigeria. That's Enugu and Onitsha. So both of them are found in Southeast Nigeria and relatively closer to each other. So for each of the states, we sampled for urban slums, each of the states, so totaling 8. And Enugu and Onitsha, they have a reasonable amount of population. So for Enugu, you have 876,000 people, and Onitsha, 1,695,000, with annual growth increase of 3.42%. So these 2 states have a sizable amount of long-standing urban slums, which is part of what informed choosing them. And also, we selected them based on convenience because they are close to each other for us, for the researcher to be able to access. So for the methods, the minimum size, sample size of 1,025 households was determined using the demographic and household survey sampling and household listing manual sample size calculation formula, which is there. So our target respondents were caregivers, female primary caregivers in these households with at least one child of under 5 years. Then they were probably more eligible if they have been living in the community. The respondent has been living in the community within the study site. Also, in the event that we couldn't find a female primary caregiver, we also sought for the male head, of the households, but on the account that he has sufficient knowledge of the household seeking behavior. So in terms of data collections, 1,225 respondents from these different households, responded to the pre-tested interview administered instrument on health expenditure and access to healthcare. So the data was collected in pairs with a researcher, one of the researcher having the hard copy of the instrument, the other researcher having a soft copy. So at the end of each day's data collection, they had to sit down and cross-check for consistency across the two. So the ethical clearance for the study was gotten from the Health Ethics Committee of the University of Nigeria Teaching Hospital and the School of Medicine Research Ethics Committee of the University of Leeds, UK. So for data analysis, all data analysis was conducted using Stata version 17. So for the first objective, remember, characterization of the socioeconomic status of the population. So we use descriptive statistics to do that. Then for the second objective, characterization of the health-seeking behavior, we also use descriptive statistics to do that. Then for the exploration of the association of out-of-pocket expenditure, socioeconomic characteristics, and health-seeking behavior, we employed gamma regression analysis. Now, finally, and most importantly, we employed financing incidence analysis, FIA, to explore the inequities in out-of-pocket expenditure among the households. So to do this, we had to calculate for the Gini index. I'm still going to explain that. Then concentration index and the Kakwani index. So results. For the results, for the demographic, for the first objective results. So we found out that majority of these households, their source of income, we are more of informal jobs. So they are informally employed. So informal jobs like petty traders, subsistence farmers, And then their education, we found that most of them had secondary, at least some form of secondary education. Then for the households in the poorest quintile across the two states, so we found that there are more poor households in Anambra State than in Enugu. Then for the respondents across the states, we almost had equal respondents. So in Anambra, we have 509 and Enugu, 516. Now for the objective 2 results, health-seeking behavior, we found that most of them utilized healthcare services for the past 3 months. Also, the most frequent health condition reported was a communicable disease health condition. Then, this is very important. So we found that there was higher frequency of visits to informal health providers than formal health providers in both states. So informal health providers are like patent medicine vendors, traditional birth attendants, as opposed to formal health providers like a PHC facility. So they preferred visiting informal more than formal health provider. So for the association, that is objective 3 results. So for the association between out-of-pocket expenditure, socioeconomic status, and health-seeking behavior, we found that those with formal occupation had low out-of-pocket expenditure compared to those with informal, compared to the informal. So the residents of Enugu, households from Enugu, spent less out-of-pocket expenditure compared to Anambra. Then households in the middle wealth quintile incurred higher costs than those in the poorest quintile. Now, wealthiest households used formal healthcare services more often than the poorest, possibly because they have more ability to pay and they can afford such the services of formal providers. Unlike the the poorest households who resort to informal providers mostly because they are cheaper and more available. Now, to the main results, to the main thing we are searching for, which is inequity. So here, you have Anambra State, Enugu and the pool sample, both of them. So this line, this black line, is a line of equity. Then this green line is the Gini index. So the Gini index is gotten from the Lorenzo curve. So that's equally the Lorenzo curve. So what this does is that it measures the distribution of income across the households. So what it tries to tell you is that the household, do they have equal ability or equal income to pay for a service? Or do some of them have the ability to pay more than others? So with this bulging out, what it confirms is that, yes, it's not equal. Some households have the ability to pay than others. So obviously, there are richer households who can pay, who have more income than others. Now, the red line is the concentration curve. So this concentration curve, what it measures is the distribution of payments. So who made more payments for healthcare? Who made more out-of-pocket expenditure payments for healthcare assessment? You understand? So looking at this, it confirms that some actually made. So it ranges from -1 to +1. So when it's in the negative side, it means the poorer households made more payments, just like James. Yeah, I think he mentioned something like that. So when it's positive, it means the wealthier households are made more payments for accessing healthcare service. So looking at this graph, you can see that the Gini index, the concentration curve is in front of this Gini index. So what it means is, remember that this has confirmed that some people have more money to pay, more income than others. And then this being in front means that those who have more money to pay are the ones actually making more payments for healthcare service assessment. So showing that the rich are paying more, and then thereby showing that there is progressive system of payment. So that is for Anambra, and then this is for Enugu. Here you can see that so this space here between this green line and the red line is the Kakwane index. So what the Kakwane index does is to assess the difference between the concentration index and the Gini index. So the wider this line, the higher the progressivity. So here you can see the progressivity, although there's progressivity, but it's lesser here in Enugu. Then for the pool sample, so in summary, there's progressive payment mechanism in the urban slums. However, so this is basically all the things I've explained. So except you want to see the figures actually. So in conclusion, we were able to ascertain that even though there is progressivity, let's not be fooled by the fact that there's progressivity, but there's a problem, which is the fact that these poorer households are actually on the verge of being denied healthcare services, even though there is progress. So this progressivity is not necessarily, we observe, is not necessarily, it doesn't come out from the fact that the rich are paying more, but the fact that the poorer households don't have money to pay for formal services. Therefore, they resort to informal more because that is what they can afford. But in the real sense of it, they should have more money. They should be able to access formal healthcare providers more often. But you can see that they don't have choice because they have been priced out by the rich households who relatively have more money to pay for such services. Now, secondly, we observe that there's obviously a disparity in access of quality healthcare in urban slums in both states. And then also, this study was able to equally buttress the point that ability to pay, which is ATP, so this ability to pay, plays a key role in healthcare denial among urban poor who are priced out of the system. Now, for the recommendation, we recommend that there should be further investigation on the causes of inequity in urban slums. So we feel that there should be more researches targeting this. So there should be more researches in inequity across urban slums, because we feel basically that this vulnerable population has been neglected. So there should be more work to find out about payment of healthcare services in urban slums. Then secondly, there's need for the assessment of feasibility costs and cost effectiveness of integrating informal health providers into the formal health system. So this is very important, because we understand that majority of the poor households utilize their health services of informal providers. These informal providers are very, very important in these urban slums. They're like the key people who provide healthcare services there. So we are recommending that there is need for such integration, so that they can be integrated into the formal healthcare service system, where they can collaborate with both formal and informal to deliver quality healthcare service for these urban slum dwellers. Now, finally, there's need to conduct a needs assessment to help gather key information on how to implement these changes. So at this point, I want to mention that while I was speaking, that one of the court has entered. So at this point, I have to thank you for listening, and you have a nice day.
Thank you so much for that very interesting presentation, Okichukwu. I know it's always very hard to summarize all your work in 10 minutes. So I really appreciate that. Thank you. So a round of applause to him as well. So we're going to take Evelyn for the next presentation.
Good evening, everyone. Thanks for coming for this presentation. So I'm Evelyn Kabia. I'm going to be presenting on informal payments for healthcare at public health facilities in Kenya, and we're going to look at influencing factors as well as the implications on equitable access. So that's going to be the outline of the presentation. So when you talk about out-of-pocket payments, they are broadly classified into two. So there are formal payments and informal payments, and my work focuses on informal payments. So informal payments are those payments that are made by patients to providers. They can be made either in cash or they can be made in kind, and they are given over and above the officially determined service fees. So generally, informal payments are considered a form of petty corruption, and corruption is just the abuse of power for private gain. So we find that in Kenya, they are quite prevalent. And in 2024, around a fifth, 20% had paid a bribe, done a favor, or given a gift to a healthcare worker in order to be able to access services at public health facilities. So why do we need to study about informal payments? It's because they limit access to care, especially for vulnerable groups such as the poor. And they also, in the Kenyan context, we have very limited evidence on the drivers of informal payments, and the existing literature has focused mostly on reproductive and maternal health services. So this work focused on examining the demand side, the supply side, and the contextual factors influencing informal payments. So this is a broader piece of work for my PhD, so this is just one objective of my PhD work. So for the study methods, this was a mixed method study, but today I'll just present on the qualitative bit, but for the other quantitative bit, we did a household survey. So we did the work in 2 counties, one urban and one rural, and we did at 8 public health facilities, that is 4 hospitals and 4 health centers, to be able to see if there are any differences based on the level of care. And then for a study population, these were patients and health facility staff. That is both clinical and non-clinical staff. So for clinical staff, we interviewed nurses, doctors, surgeons, healthcare workers working at the lab, those working at pharmacy. And then for non-clinical staff, we interviewed people like security officers and cleaners. Then for sampling, we used a purposive sampling approach, maximum variation sampling, to ensure that we got a diverse range of respondents. Then for the data collection methods, we did focus group discussions with the patients and then in-depth interviews with the health facility staff and the managers. So moving on to the results, looking at the demand side, these are factors related to the patient, to the community. So we find that patients had various motivations for paying informal payments. So for those who paid, most of the informal payments were made before services were provided, and patients made them to access care or services, or to be able to get commodities such as drugs, sometimes bed nets, or to get patient registration booklets. But there are also people who paid because of desperation for care. Because where we did our study, it was an informal settlement, and in Kilifi, it's a bit rural. So we find that people of low-income groups tend to rely mostly on public health facilities, and also sometimes they may not be able to afford care at a private facility, and also so they lack alternatives. Then the other reason was to get, or in an attempt to get higher quality care. So this could be timely care, maybe to skip queues so that you get shorter waiting times, to get safer care, to get more individualized care. For example, some patients who are taking HIV drugs would prefer to get the drugs, the provider to give them the drugs privately as opposed to picking them at the facility because of the stigma that is associated with it. And then also some also paid informally just to be able to be served by a reputable provider. Then other reasons was to reduce the financial hardship from high medical bills. This was mostly for inpatient bills. When they were too high, so the patients and some of the healthcare workers would collude either to help the patient escape the facility, to pay informally and escape the facility, therefore avoid paying the bills, or you pay less bills, some of it you pay formally and the other you pay informally. Then some informal payments were also paid after service delivery, and these were considered gifts to the healthcare provider, especially where the patient felt they were happy with the services that they received. But it's a bit tricky to really tell what is a true gift, because sometimes some patients can give these payments as insurance for future care, so that when I come next time, let's keep this going. Yeah, so it's a bit tricky to tell a true gift. Then on the supply side, the economy, when you look at health service factors, so informal payments cut across most of the health services, but they were more common for services that were provided within the outpatient department, that is consultation, lab services, radiology. And this was mostly, especially at the higher level facilities, the patient volumes are very high, so the queues are long, so there's an incentive to pay informally to be able to get quicker services. Then they're also common for services that were charged compared to free services. So for example, if they went to hospitals and the service price lists are not updated, then it's very hard for a patient to tell what is the actual cost of care. So you can end up paying informal payments. And then for specialist services, so specialists tend to be few within the Kenyan health system. So it means the waiting list, maybe at the specialized clinics, can go into months, so that there's an incentive to pay informally to be prioritized for care. And then for non-routine or seasonal services, such as male circumcision and filling of school medical forms. So this was mostly at primary healthcare facilities, where we find that maybe these services are not within the scope or that level of care, but maybe the clinical officer has the skill. So they can, instead of referring the patient to a higher level of care, they can charge you informally and give you the service. Then the other one was pregnancy-related complications, mostly induced abortions, and this was related to negative healthcare worker attitudes towards abortions, where they felt you as the patient, you induced the problem, but you want me to handle it. So they charged informally instead of giving the service for free. Then looking at the economic factors, the main drivers of informal payments were just scarcity of resources. This was shortage or lack of health commodities. So you find that if there were shortages, some healthcare workers would try to fill in the gap by procuring the commodities and selling them to the patients at a profit, or sometimes pretending that the things were out of stock and selling them to the patients. The other issue was low and delayed salaries. And this mostly affected support staff like cleaners, security officers, where you'd find that during the study, the delayed in salaries range from 2 months to 12 months. So charging informal payments was a way for them to keep working. It was like a survival mechanism for especially for those lower cadres. Then the other issue was healthcare worker shortages, which led to high patient workloads, health worker fatigue. So charging informal payments was a way of like motivating themselves because of the harsh working conditions. Then other factors was inadequate oversight over the healthcare workers as well as the health facilities. And then in some facilities, the health facility managers are also engaged in charging informal payments or colluding with other health facility staff. So that becomes very challenging for them to offer adequate oversight over their staff if they're also engaging in informal payments. And then just political interference in the disciplinary processes. So they were long, or there would be influential or top-level managers who would interfere with the discipline process for those who are caught engaging in informal payments. And then just ethical factors. Some felt charging of informal payments was based on individual healthcare worker values. Some felt maybe some healthcare workers were greedy, your level of empathy, how you were brought up, your character, people's religion. So some associated it with a bit of morality. And then some felt it's just unprofessional and unacceptable to ask for informal payments. So we find that these payments varied across health facilities. They were more common at public facilities, and this was mostly because of unavailability of commodities and the limited or inadequate monitoring. And then at urban facilities, mostly because of the high patient volumes, and also people felt that urban residents have more disposable income compared to people living in rural areas. Then they're also more common at higher level and referral facilities. This is because they tend to offer specialized services and a broader range of services. Then you also know that the context within healthcare is provided also influences informal payment. So there were socio-cultural factors. So we find that in Kenya, there's a bit of a culture of bribery within the public sector. And then there are societal beliefs that for you to get good services within the public sector, you have to pay a bribe. So this kind of contributes to high acceptability of bribes as well as its normalization. And then we find that when some healthcare workers were aware that their colleagues were engaging in informal payment, it kind of promoted that behavior. It's more of a collective action problem. If you know other people are engaging in corruption, then why not? So they will tell you, even if I don't take this informal payment, the next provider is going to take it, so why not? Then politically, we find that the public and the healthcare workers felt that the leaders, politicians are corrupt and there's lack of political will. So this kind of encouraged also the public officials to also engage in rule breaking. Then economically, the level of inflation was high, low purchasing power. So some healthcare workers felt that their salaries are not adequate. So getting this extra money from informal payment was a way of bridging that gap. Then we find that informal payments have negative effects. So I'm just going to focus on the negative effects for those who are unable to pay. So for those who are unable to pay, it limited their access to care, where you find that either care would be denied or postponed. You'll be told, come next week, keep coming next week until you get the hint that you actually need to pay a bribe to be able to access care. And then when patients knew that these facilities, informal payments are charged, they tend to bypass those facilities. And then the perceived quality of care. So some patients felt like they lack confidence in the treatment. So for example, they would feel like, since I've not been able to pay, maybe they're giving me substandard care. And also, of course, you end up having to wait longer because the healthcare provider will prioritize whoever has given a bribe. Then it increases financial hardship because some of them are forced to forgo their needs, like food, or they have to borrow or sell some of the household assets. Then for the patient-provider relationship, it leads to negative emotions from the patient side. Some fear being victimized in future visits because they refuse to pay an informal payment, as well as their emotions such as anger or bitterness towards the healthcare workers, and some feelings of shame from the healthcare workers. For example, if you ask for a bribe and the patient refused or they're unable to pay, some reported feeling ashamed, and that kind of spoils the rapport. And then for the health facilities, informal payments divert money from the facility. So this led to reduced revenue for health facilities, which impacts service delivery and the ability to run just general operations, and also leads to loss of trust by the community. So in conclusion, we find that most of the key drivers of informal payments in Kenya is just inadequacies and weaknesses in health system financing and governance functions. And as we've seen, they have a negative effect on people accessing care, and they also increase financial hardship. So as we've seen for policy consideration, we've seen there are various factors that influence informal payments. So it means we need to employ a multifaceted and a multi-sectoral approach to tackle corruption. And then there's need for increased prioritization and public spending in health to be able to address these system level constraints, then strengthening governance structures as well as greater political will to curb corruption. And some of the demand side factors is enhancing public awareness of health services and the related costs. So I'd like to acknowledge the following for their support and contribution, especially my supervisors. Thank you.
Thank you so much, Evelyn. Another round of applause as we, very interesting findings. And one of the problems that, I know many African countries are facing as well. So last but not least, Maria.
Gonna have both, but yeah, thank you. Yes, sorry for bearing with us. Last presentation of the day. Hopefully interesting enough to keep your attention. So this is slightly different. This is looking at healthcare financing for refugees, which is obviously a very vulnerable population, but we haven't heard much about refugees and migrants in the conference so far, or at least I haven't. So sorry, just to start with, this is part of work that we're doing with UNHCR. And to give you a little bit about the background and global context, as many of you know, Okay, so as many of you know, the number of refugees is increasing, and what is most important, displacement is becoming more and more protracted. The traditional approach to take care of the health of refugees was to set up of a parallel health system, right? Within the camp, NGOs or international organization would come in, set up a clinic, and funding will remain completely separate. However, as displacement becomes more protracted and the numbers increase, there is really a question of sustainability of that approach. There is a fragmentation, there's duplication of cost, there is a lot of difference in terms of quality of care between refugees and host population, and this is not really sustainable in the longer term, both politically and also financially. So there has been increasing call for integration of a health system for refugees, so that the refugees, they integrate and they are included within the local health system and access health services in the same way as the local or host population. So, but still, there isn't much evidence about how to do that, both in general for health systems, but also specifically on health financing, which is what I will focus on today. So we're doing this study for UNHCR, where we're developing 6 country case studies in a number of countries. But the first step that we did was to do a review of the literature. And so in this study, this presentation, I report on the literature review. We reviewed both normative and empirical studies, looking at health financing arrangements and also the level of integration. And the aim was to highlight lessons and develop hypotheses about what worked and what could work and why regarding the integration of refugees in regarding of health financing. So briefly on the methods, it's a very rapid literature review. You have a number of countries covered, in particular, some countries are more covered than others, in particular Uganda, and it's definitely a growing area of research. In total, we identified 52 documents and we reviewed them. And to structure the analysis, we used the health financing functional framework of the WHO, I'm sure you're all familiar with, looking at revenue raisings, pooling, funding, and purchasing and benefit packages. So we start with revenue raising. So what we try to do, it's both to look at the challenges, but also what are the approaches that might work to integrate health financing arrangements for refugees. So obviously the main challenge that we all know is that there is decreasing external funding, which has been traditionally the main source of funding for refugee healthcare. At the same time, host countries are providing a significant amount of funding, but that's not enough. It's still not enough. And it is also very politically difficult to increase it because refugees are often not allowed to work, and so they don't pay taxes, they cannot contribute to social health insurance. So politically it's difficult to raise domestic funding for refugees because they're not contributing to the system. The literature also finds that there are really high out-of-pocket by refugees themselves, despite being one of the most vulnerable population. When we look at the literature, there is really not much about integration, but one of the key issues that emerge is that integrating at the level of revenue raising, it's very politically sensitive, because it would mean that the burden sharing wouldn't be very equitable if the revenues come to the refugee hosting countries and some other countries that are not hosting refugees that they don't have to pay. So one of the points is we have to be careful when we want to integrate health financing for refugees in terms of revenue raising, we have to be careful that there is a fair burden sharing. They are not only the country hosting refugees that they have to increase their funding, and the other countries that don't have that problem. So there is really a need to keep, in a sense, keep at least a bit of parallel funding and external funding, so not to make the burden on refugee hosting countries too high. And different options are highlighted, and a main one is the engagement of development donors, for example, the World Bank. Traditionally, refugee healthcare has been funded by humanitarian sources, and development donors have not been particularly interested. But with this kind of increase in the length of displacement, the permanence of refugees, and the high cost, and therefore the integration processes, it is becoming more and more important to involve development funders. And the World Bank has opened now windows of concessional lending and grants specifically for refugees and host populations. When we look at fund pooling, what we found is for now, until now, only a very small percentage of funding is channeled through the governments that are hosting refugees. However, there is a tendency, a kind of like a kind of aim to try and reduce fragmentation and promote integration. And when that is not possible through national budgets, there have been attempts to create pooling funds of external resources, such as the joint response plans in Pakistan or in Jordan. However, it's important to think that when pooling has kind of a double function, we can pool the funding, and it also kind of, not automatically, but it can lead to also an integration at the health service delivery level. So fund pooling can be leveraged to achieve also integration of service delivery. And this has been the case, for example, in Uganda, where refugees have been integrated into the health system, and the funding is going directly to the district in the same way the funding for host population. In Lebanon, it's also a similar example, although the situation is much, much more fragmented because the system is more fragmented and privatized. And what we found in the literature is that one of the entry points is the social health insurance. If a social health insurance is in place, that is a very good starting point for integration, because the refugees, either directly or through external sources of funding, such as UNHCR or other donors, can pay premiums, enjoy the social health insurance, and therefore access services as in the same ways as the host population. So we found that fund pooling is a potential entry point for integration to reduce fragmentation and move toward integration also in service delivery. Then when we come to purchasing and provider payment mechanisms, there isn't really much in the literature. Obviously, when the approach is parallel, oftentimes there is a contracting out method. So UNHCR or other international donors would contract out international NGO or national NGO to provide health services. When systems are integrated, there is really not much evidence. Usually the assumption is that provider payment mechanisms would be the same. If refugees are using the same facilities as host population, they will be the same as the rest of the country, so the same level of fees for the providers, the same type of reimbursement. But this can raise issues because the cost of service delivery for refugees might be higher because they have higher needs, because they need longer appointment, because they need language translation or other services that the local population would not need. Finally, we look at benefits, equity, and efficiency. And this is where, one of the biggest paradox of integration comes out. Often benefits and entitlements are much broader for refugees than for the host population when the services are provided in a parallel way. So that's the situation we find in many countries where refugees have access to better quality of services, extended packages, and especially they have access to services for free, while the local population living next door but outside of a camp has to pay user fees and have less quality and less kind of less large benefit package. So integration would, in a sense, be paradoxically require a reduction of benefits for the refugees, which is also politically quite difficult to do, especially for humanitarian organizations that are used to those humanitarian standards. But it is also an important step towards integration, and it needs to take into consideration the differences in needs and address financial barriers for refugees that might be higher than the host population because of their vulnerable status, or legal or administrative barriers or other type of barriers. we didn't find much evidence on costs and cost effectiveness. There is a kind of assumption in the literature that moving towards integration would reduce cost and be cost effective compared to a parallel approach that is often characterized by duplications, overlaps, and inefficiencies, but there isn't really much evidence on that, much quantitative evidence. And there is some evidence of improvements in equity, especially when in terms of kind of equity between host population and refugees, when the health services and the health financing arrangements are integrated. So a few key messages to conclude. First of all, when we talk about integration, it's important to realize that both what we observed in reality and also the ideal level of integration is really something that varies across the spectrum. It's not, yes, services are integrated or health financing arrangements are integrated, yes or no. It's more like the level of integration. And it's important to understand that the ideal level of integration might not be the same for delivery of care, but also within health financing for, as I said, revenue raisings, where we think maybe less integration is better because it's politically more viable and it allows for extra revenues from external sources, but pooling, where we really think integration is really important to achieve because it leads to integration in service delivery. So it's important to consider all these variation and understand integration along a spectrum. The second point is that integration reflects the arrangement of a national health system. If we're integrating refugees in a system that it's fragmented, privatized, very costly, and so on, like the Lebanese health system or the DRC health system, obviously this is going to lead to care for and health financing arrangement for refugees that is the same, fragmented, weak, unequitable. Then, as I mentioned a couple of times, fund pooling is definitely an entry point for integration because it avoids those negative narratives around the use of domestic resources and reduce fragmentation, strengthening the health financing arrangement of a health system, because then the resources are channeled to the local health system, which can be strengthened for both host and refugees. Revenue raising can be leveraged strategically, including, for example, development funding, but it has to align priorities of both refugees and host population. So thank you very much, and I also want to acknowledge my, my co-author and UNHCR funding. Thank you.
Yeah, thank you so much to Maria. Another round of applause. So we are left with a very difficult situation. We have 2 minutes to the time, and I know this is a lot of information in just an hour. I'm going to take 2 questions, quick questions. We'll start with this and then here.
Yeah, I have all the presentations were very good, so it's hard to select which question to ask. But I will ask the question to the second presenter, who presented on James, I think, Okova, who presented on. Oh no, it's not James. It's James Oguta, sorry, who presented on the ideal CVH. I understand that you use Kenya. Where is? Okay. I understand that you use Kenya DHS survey from the WHO.
Yes, step survey.
Right.
Step survey.
So, and one of the questions of interest is to look at the ICVH on inequalities, and you find that it increases the likelihood of inequalities among certain groups, like women. But I was wondering, is that also kind of related to the use of the DHS? Because my understanding from the DHS survey is that they tend to be biased toward women, to oversample women. So does that affect your results in any way?
I don't think so, because the survey is designed. I think the design is the same, but if you looked at the table that I showed, different matrices have got different patterns, so it's not in any way related to the design of the survey. Yeah.
Okay. And then among the symptoms that affect the CVH itself, do you find any particular criteria that is more likely to affect inequalities? Like you look at behavioral versus biological, smoking versus, is there one that is particularly important in increasing inequalities among women, among those biological and behavioral characteristics of the CVH? Yeah.
Yeah, so most of that is related to BMI as a risk factor, which is more pronounced among women. And there are studies that have also shown central and abdominal obesity as more prevalent among women. Yeah.
Thank you. Yeah, we can go to this one, and then let's take your question and we take hers so that we respond together to the both questions.
Okay, so my name is Catherine. My question is to Evelyn and yourself. I think it's a bit tied when you're saying that informal payments related to, appreciation or a gift, especially after the services. So the bit of whether that should be included, like when you're estimating your catastrophic health expenditure. Do you include informal payments? For example, someone is treated and they feel well and they decided to gift the doctor a goat. Will you value that goat and include it as part of your out-of-pocket expenditure? Yeah.
Very good one.
Thank you so much. My questions to the informal sector presentation, I forget her name, yet we've met before. They are just for my understanding because I do work that relates to this. So about the demand side factors, you said that they were paying to access the services and commodities. So my question is that couldn't these patients go to the private sector, private healthcare providers, to access these services than paying for the services in the public facilities, if that was one of the factor? The other question, again, for my understanding, is why would a patient pay a security person if they have come to seek services, or a cleaner? I understand if it's a medical personnel, but security person and cleaner, I just wanted to understand that. The other question is for the last presentation. Thank you so much for the great presentation. I am just wondering, when you say that the high out-of-pocket expenditures for refugees themselves, and is it for, and this might be outside your study, but I was thinking maybe the healthcare system that you're looking at is already experiencing high out-of-pocket. So it wouldn't be different if the host institutions are experiencing out-of-pocket costs. Definitely refugees would. And so I was trying to ask myself, would this be peculiar to refugees alone? Or it's just that the health system, that where they are, actually depends on out-of-pocket expenses? The aspect, the last one, the aspect of social health insurance, I'm not very comfortable with as one of the integration part, because you categorically say that I'm trying to question how it will be working. For instance, the governments are already constrained, right? And then the host institutions, the humanitarian payments are not predictable. The refugees are not working. So this social health insurance proposal, how practical is it?
Thank you. Let's hear the responses to those. I know there's another session at 5:15, so.
Thank you, Catherine, for that question. So in my study, we're not explicitly capturing in those informal payments, but as a general answer, I think it would make sense to capture them in future studies, because they lead to financial hardships, especially for low-income households. So yes, they should be captured. I wish I had that idea earlier. Anyway, thank you though.
Thank you.
Yes, thanks, Catherine. So part of this was a mixed method study, and we also did a household survey in the 2 counties. And we also asked the patients, the household members, the reasons. And so we were able to tell how many gave an informal payment. or a gift to express gratitude and how much it was. So we have that information. Then, yes. Yeah? The gift in kind. Yeah. 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 So now you ask them to give you the rate. Like if it's a chicken, how much is it within the current rate, within the market? If it's 1,000, then that's the amount you're going to put as the amount of the gift. Then for the demand side factors, you had asked about why they pay instead of seeking care at private facilities. We find that mostly the communities we interviewed were living in informal settlements, and some of them in very rural areas. So they are very low income groups. So they really can't afford, most of them are not able to afford private care. And some of the healthcare workers would say how patients would reason is that even if I go to a private facility, the informal payment I'm going to pay here is cheaper than going to a private facility. So I'd rather just pay the bribe than go and get care to a private facility. And then why pay to a security person? So you find that in most facilities, especially the higher level facilities, the security guard is the first point of contact with the patient. Like for most patients, they don't know their way around the hospital. So they're more likely to ask the security officer, so I'm seeking this and this service, so where do I go? So we find that in our study, there was overt collaboration between clinical staff and non-clinical staff, such as security officers, in charging of informal payments. So they'd have arrangements, maybe a clinical officer and a security officer, to tell them, if you see a patient coming to ask to be filled for a medical form or they want male circumcision, send them to me, and then they would share the commission. Sometimes also patients pay security guards, like if you're late for visiting hours and you want to be allowed to go and see your patient, so you give them something. If you want to be allowed to bring food from home, you give them something. The same as cleaners, to be allowed maybe to get better clothing, if you want warm water. Yeah, so sometimes they'll give those informal payments to get better hotel services within the, so mostly all the cadres within the facility, clinical and non-clinical, all of them kind of, in the Kenyan system, they kind of engage in informal payments. Yeah, thanks.
Very interesting.
Yeah, not unknown, but it's hard. It's striking to hear it, right? Indeed, very interesting research, Evelyn. Thank you. Yeah, just to address your question very quickly, I think out of pocket obviously varies a lot between different countries. So in some countries, services for refugees are free and very good, and so out of pocket most of the time is like pharmaceuticals or extra things. Sometimes there isn't much, and so but usually, I'm thinking more kind of like in Lebanon, for example, where the system is really privatized. So the public facilities that are providing services for free to the refugees, they're overcrowded and they're not doing very quality, and so they would go to the private sector. But that varies depending on different countries. And also to link to your second question, it also varies on the policy that the country has. Some countries have an encampment policy where refugees are not allowed to work. Other countries have no encampment policies and refugees are allowed to work or not, different combinations of that. But I think if the idea is, and the kind of call at international and national level is for integration, integration has to happen in the health system, for a health financing arrangement, but also for broader societal integration. So starting with refugees being able to work. And this is where the social health insurance bit comes in, because in countries, and Latin America is a good example, where social health insurance is there, that has been a kind of a tool to provide services for refugees where, South America, there's no camps, so there's no encampment policy, but refugees access services through the public system using social health insurance. So the system's not perfect, but it is an entry point. And so that's what we found in the literature as a starting point, as one of the options to start with.
And maybe to add to that, for instance, in Rwanda, we have a system where they automatically, money from UNHCR to the refugees automatically flows through the health insurance so that they can, already access the services. I had a quick one for him, for Kechuku, and so you talked about how the richer pay more, but also access more formal services. Is there an aspect of the fact that they also tend to have health insurance as opposed to informal sector? So that, okay.
We found out in the study that majority of these richer people are people with formal employment, and most of them are usually federal government workers that have health insurance embedded in their work. You understand? So because of this, it's easier for them to make such payments. So part of what we're equally advocating is that health insurance schemes must be able to acknowledge the fact that the real people that need these insurance schemes are the informal, the people with informal occupations, jobs like petty traders, farmers, because these guys don't really make enough money to. So I don't understand why you are giving health insurance package to people who may even likely provide access such health and pay for them, and then leaving out the key people you're supposed to be the insurance package should be protecting.
Yeah.
So that's part of what we found out.
Thank you so much. The question of informal sector and insurance is a conundrum to fix, but yeah.
Hi, my name is Tabiso, and mine is more a comment. I'm just wondering if there are ways to channel this corrupt money into the system. So in South Africa, I don't know if we still have it, but they've got those units within public sector facilities that they call folateng. So it's almost like a private ward. If you've got enough money, you can pay to access quicker services, but it's not as high as in the private sector. So it's almost 50% of what's happening in what's being charged in the private sector. So you almost channel that money to use it to strengthen the whole facility. But yeah, it's for people who can afford it, but they can't quite afford the private sector.
Yeah, that's.
I love your research. But I just wanted to find out, you said something during your presentation. You said that the informal payment was more in the public. So did you do a comparison with the private and public?
So let me start with yours. So this was more of, so we obtained the patients who are seeking care at public facilities, but they could share their experiences because they've also sought care at private facilities. So they could be able to share both. But in the household survey, the preliminary findings showed that like 75 to 80% of the informal payments are paid at public facilities compared to private. So it's consistent with this data. I don't know if I understood your question, but yeah, okay. Yeah, but I think from what we got from our work, most of the informal payments are mainly, I could say it's abuse of power for private gain, other than the few who use it for survival corruption, because your salaries are really delayed for months. Like, how do we expect them to survive? For sure, they have to find a way of surviving, of staying in the system. But most of them, the money goes to their pockets. It goes to healthcare worker pockets. Yes. So I think we also asked the patients and the healthcare workers, what are some of the measures they felt would help to more feasible measures to tackle informal payments. And some of the healthcare providers, the issue was that there is no transparency on health, how much the facility gets and how much is spent. So sometimes when they don't really understand, they are forced or they are motivated to ask for informal payments because they feel, oh, we help in generating so much revenue for the facility, but we don't see how it's trickling back to us. So they felt if there was more transparency, we are getting this as a facility, this is how we are spending it. Then they may be incentivized instead of taking this money to their pockets, to directing it to the facility, but also the facility needs to make sure that there's a way that the health workers benefit. And some of them are very simple ways. They would say, give us tea, give us lunch, give us certificates for exemplary service. Some of the measures are really feasible to implement here. But thank you for that.
Yeah, thank you so much. I won't take any questions. One suggestion I will give. We're here for the next 2 days. I think the presenters, if you see them around the corner, you can, have a chat with them. Let me call upon the presenter for a picture, one for the presenters, and then probably another one for the people who are in the audience. And a round of applause for them. It was a very, very interesting discussions. Yeah. Thank you all for the engagements and for the questions and discussions. Let's take that picture, and then I think there's another session happening in MH1 and MH2.